Hello friends, I am Dr. Deepak Garg. I am an orthopedic surgeon and today we are going to discuss a very hot topic, that is direct anterior approach to total hip replacement surgery. Let's first talk about the position of the patient in the direct anterior approach. So we keep the patient in a supine position. We may use a HANA table or a breakable plane table. The table should be breakable at the center so that whenever we want to achieve the hip extension, we can easily achieve the hip extension. So it should be a breakable table from the center. So we keep the patient in a supine position. We use the side support and we prepare both the legs. We have to prepare both the legs and we use a breakable plane table or a HANA table. So this is the positioning. So after the painting draping, we will start marking the surgical landmarks. So our surgical landmarks here will be, we will first mark the ilium, then we will mark the anterior superior iliac spine. So these are our surgical landmarks. So once we have these landmarks, we will mark our skin incision. So our skin incision will be, so we from our marking, this is our ASIS. So we will come 2 centimeter lateral. So this is lateral and we will come 2 centimeter inferior. So this is inferior. So this is our starting point. So we will first mark our starting point. So this is our starting point. So then we will look at the lateral end of the lateral border of the patella or the fibular head. So these are the imaginary landmarks that we have. So from this point we will move towards the fibular head. So this is the line of our skin incision. So this should be kept in mind. So during the initial phases of your surgery, these are particularly very important because these will help you identify the plane. So then we will take the skin incision. So once we take the skin incision, we should already know the plane that we are going to go. We will go between the sartorius muscle and the tensor fasciae lata muscle. So, and we should know that the lateral cutaneous nerve of thigh will come through this tensor fasciae lata. So we have to preserve this nerve. Otherwise, the patient may have loss of sensation on the lateral aspect of the thigh. So this nerve will run through the fascia from the lateral aspect of the fascia. So we will first identify the plane between the sartorius muscle and the tensor fasciae lata. So from the plane here we can see that so this is we already know that this is the anterior superior iliac spine, and this muscle is a sartorius muscle and this muscle is a tensor fasciae lata. So from here we can identify our plane. So our plane will be this is our plane, this is our plane. So and this muscle, there is another muscle. So if we look at this, so this muscle, this muscle, so this muscle is a rectus muscle. So this is a rectus muscle. So from here we can see that if we are proximal, then it is easier to identify the landmark. So always first try to palpate the plane from the proximal to the distal. Never try to palpate from distal side. This is a very easy mistake that we do in our initial surgeries. So we should avoid this mistake. We should first palpate the anterior ilium, and from there we should come approximately 5 centimeter. And there we should try to palpate with the finger the gap between the two muscles. So at this level we will be easily able to identify this gap, and from the gap here we should retract the sartorius muscle on the medial side, tensor fasciae lata on the lateral side, and we should try to cut on the medial side of the tensor fasciae lata. We should cut the fascia on the medial side of the tensor fasciae lata so that we will be able to preserve the lateral cutaneous nerve of thigh. So once we have this plane, we palpate this plane and we track the sartorius on the medial side, tensor fasciae lata on the lateral side. So once we do this, so this is just to show this nerve. So this is sartorius and this is how this nerve is traveling. So we have to trace the gap, then we should go along the medial border of the tensor fasciae lata muscle, and we should know the relation, all these relation of the muscle. So we can see here that this femoral nerve and the vessels are lying medial to the sartorius. So we should try avoid going medial to the sartorius muscle. So once we have this, then we will retract the tensor fasciae lata on the lateral side. So once we retract the tensor fasciae lata on the lateral side, then we will expose the structures below it, and then we will have we can see that this is a rectus muscle. Rectus muscle has two origins. So this is a rectus muscle, we can see here, and the rectus muscle is having two origins. So the one of the origin is coming from the supraacetabular area, and one of the origin is coming from the ilium. So these are the, and it has an attachment on this. This is a capsule above and below. So this has an attachment on the capsule also. So we have to release this attachment of the rectus muscle from the capsule. For that we use this corpse elevator, corpse retractor, and with the corpse we insert the corpse between the capsule and the rectus muscle, and we release this attachment so that we can easily lift the rectus above. So we will lift the rectus muscle, we release this attachment, and we release this muscle. So this is how we will free the capsule, we identify the capsule. So with this we release this capsule, and once we release this capsule, so we then put a retractor on the medial side of the neck of the capsule, and on the superolateral aspect we can see these are the attachment of the gluteus medius and the minimus muscle. So we put another Hohmann retractor on the superolateral and inferomedial side. So this is inferiomedial, this is superomedial. With the corpse retractor we will release the attachment of the glutei muscle with the capsule. So we attach on both sides of the neck. Then we will have to retract the superior aspect of the capsule. The another retractor is retracting on the lateral side. We will put the retractor below the GT on the lateral side to retract the lateral side, and the one retractor, this is a very angled retractor, we put this very angled retractor on the pelvic brim so that we can fully expose the capsule from all around. So once we have this, then we will mark our capsulotomy incision. So we can take a T-shape incision, or we can just incise the whole capsule also. We can do this also, because the anterior capsule is not making very much significant role in the stability of the hip joint. So in many of our cases where the patient is obese, we will try to cut the whole of the anterior capsule. We cut the whole capsule instead of saving the capsule. We cut the capsule. So once we cut the capsule, we will expose the neck, and we have all these 4 retractors in place. We remove the medial, superomedial and the superolateral and the inferiomedial retractors. We insert the retractors into the capsule, and then we will mark our neck osteotomy. So here we will take 2 osteotomies. Why we take 2 osteotomies? Because when we will take one osteotomy, we will not be able to remove the head. So this is our first osteotomy, and this is our second osteotomy. In this way, we make a ring shape osteotomy, and we remove this ring shape osteotomy outside, and then we can easily get a corkscrew inside the head, and we can then remove the head. So this is how we will remove the head, and then we will keep these pelvic brim retractor in situ. We will keep the lateral retractor, and then we will prepare for the acetabulum. So our one retractor that is on the pelvic brim is there. Our lateral retractor we will remove, and then we will put inferior to the acetabulum, and then one retractor we will put on the superior side, on the superior aspect of the acetabulum. So this way we will expose the whole of the acetabulum, and then we will start rimming, and then we will put the hip implant, the final hip implant. So as per the preoperative planning, to understand the putting the final hip implant, we have the pre-operative planning of the hip replacement in our another video that you can go through. So once we do that, then we will prepare for the femur. This is a very crucial and very difficult part of the surgery. So to prepare the femur, it is very difficult to get the femur out. So this point is very cautious. To get this femur out, we have to follow certain very specific rules. Number 1, we have to put the patient in figure of 4 position. where one leg is, the operative leg is below the non-operative leg, and we do adduction and hyperextension, and we put the breakable table into 30 degree of the extension, so that the hip is in 30 degree of extension. Actually, the whole idea is we want to bring the femur out of the wound so that we can prepare the femur. So first, number one thing is we have to do the medial capsulotomy. First, we will go do the capsulotomy. We will go reach the lesser tubercle so that we are sure that we have done the medial capsulotomy. Then we do the lateral capsulotomy. So for the lateral capsulotomy, we will run our cautery along the lateral aspect, and we go till the piriformis fossa, and we complete the lateral capsulotomy. Then we have to do the posterior capsulotomy as well to some extent, till the time we get the fat pad sign. So we run the cautery along the border of on the bone only, on the greater trochanter, and we run on the posterior or the medial side, and then we get the do the capsulotomy till we get the fat pad sign. So once we complete this capsulotomy, then we push the femur with the bone hook. We try to get the femur out of the wound, and once we are able to move the femur, we are able to get the femur out. We keep the limb in figure of 4 position, in adduction and in hyperextension, and this is how we can get the femur out, and then we start the femur preparation. One thing that we need to remember for this surgery is please use offset jigs. This is very compulsory. Don't do this with the normal total hip replacement instruments. If you will use the normal total hip replacements, there is a very high chance of getting a GT fracture. Please don't do that. If you are not having the instruments for direct anterior approach, please go through the posterior or the lateral approach. Please don't go through the anterior approach. So this is how we do it. So once we prepare the femur, we put the final implant into the femur, and then we reduce it with the traction, and with the 2-finger technique, we just give a traction and push the femur head inside. We check the stability and the leg length, and this is the complete total hip replacement surgery. So to understand about how we put the component, what should be the positioning of the component, or inside the femur or into the acetabulum, how the C-arm will help. So we can continuously use C-arm in this case, because the patient is in supine position, we can easily get the C-arm from the opposite side. So this is about it. So this is about the direct anterior approach total hip replacement surgery. Thank you for watching this video. We will continue making these educational videos. If you want more videos, please put in the comment box which kind of videos you want. Thank you guys. Thank you very much. Thank you very much.